Hi, good morning. My name is Jayant Krishna I'm from India. And I have a very special guest today, Dr. Azra Raza, who's a professor of medicine as well as the director of the MDS Center at the Columbia University in the US. And, she's also the co-author of a book on Mirza Ghalib. So I was telling her jokingly, that I'm sure your patients get treated as much by your poetic interventions as the healthcare interventions. Even before knowing her in person, I have been, watching her videos, and let me tell you, they have been very, very fascinating. And Ghalib is a person, which connects Urdu-loving people all over the world. So thank you, Azra ji, for being with us today. And it's a very, very fascinating book, that you have written. It's called The First Cell and the Human Costs of Pursuing Cancer to the Last. Cancer continues to be a very dreaded word, as we all know in the world that we live in. Almost in 2020, almost 19.3 million new cancer cases were reported, and almost 10 million deaths. It's very, very ironical. The moment you hear about somebody suffering from cancer, a sense of helplessness surrounds the patient and the family and the attendees, unless it is detected in the early stages. So, a lot of, research has happened. It continues to happen. So reading your book, I somewhere I got confused that, what do you see, the outcome of cancer research, and the way the treatment and the early detection and the treatment is there. Do you see the glass, as half full or as half empty, Azra?
Thank you very much, Jayant. Let me begin by saying what an honor it is for me to be on stage in India with you, and the time that you are taking to be my interlocutor on this subject that really affects all of us, because 1 in 2 men and 1 in 3 women are going to get cancer in their lifetime. So cancer is no longer something that happens to other people. My own husband, who was the head of the cancer center at the university in Chicago, got the very disease he had dedicated his life to cure since he was 15 years old, leukemia.
Leukemia.
Yes, and he died an extremely painful death after suffering from it for practically 5 years. I want to begin this conversation by setting it in the context of human anguish first. So, Jayant, when Harvey died, a few weeks later, my daughter Shehrazad, who was 4 years old when he was diagnosed and 8 years old when he died, she got an infection, like a flu or something, and started getting better slowly. But a week later, she suddenly came out of her room one morning crying hysterically. And as a mother, I immediately thought she's had a relapse. I said, "What's wrong, honey? Are you feeling worse?" And she was inconsolable for a while. Afterwards, when she calmed herself down, this is what she said, Jayant. She said, "Mommy, actually, I feel fine now. But now I know how horrible it is to feel sick and how good it is to feel better. And my dad never got better." And this is the issue, that of the 20 million people diagnosed globally with cancer today, 10 million will not get better. So no matter which way you look at it, whether it's half empty or half full, the truth of the matter is that the same 50% people are dying today as they were in 1971 when President Nixon in America declared war on cancer. Now in America, the statistics are a little bit better than globally. Here, about 36% people die instead of 50%. But that gain is not from any great new treatments we have developed. It is from early detection and anti-smoking campaigns. That's it. The new treatments have maybe made a difference of, say, 100,000 deaths are being saved more annually. But that is nothing compared to the 1.8 million diagnosed in this country also. And the second problem I have is that the people who are being cured, what are we curing them with? Slash, poison, burn. The same treatments we have been using for 100 years. So where is all the progress we were supposed to have?
Absolutely, Azra, very, very well put it. I think what I admire about the book is that it has analyzed, cancer from every conceivable angle. Of course, being a doctor, from the medical or healthcare point of view, from a scientific point of view, from a cultural point of view, as well as a personal point of view, is how you have analyzed it. Azra, world over, almost 150 to 160 billion dollar is spent on cancer every year, largely for treatment, and I'm sure part of it goes into research as well. But as you rightly said, in the last 5 decades or so, major breakthroughs have perhaps not happened. Still the treatment, revolves around surgery, radiotherapy, chemotherapy. So, with such a heightened sensitivity around cancer, with such huge number of cases coming up in every country, why do you think those breakthrough interventions which have happened in technology space and IT space or other aspects of medicine and surgery as well have not happened in cancer? Is it the money available for cancer research worldwide, is it not good enough? Or somehow, while the practicing oncology has attracted the best of breed people, is it that the cancer research has not attracted the best of breed people? Or they are isolated projects, and perhaps we need to work on better research projects, or there's less collaboration among different cancer research facilities all over the world, and more of meeting of the mind, so that the wheel doesn't get reinvented again and again and again. So why is it that in every other aspect of life there have been breakthrough interventions in last 5 decades, and especially in the last 2 decades? Why is it that those amazing interventions have not seen the light of the day, in cancer?
Amazing, because the kinds of questions you are asking, Jayant, are on my 3 a.m. agenda. These are the questions that keep me awake at night. It's so easy, so facile to simply say we don't have enough money. And every individual who's in cancer at any level in America, if you talk to them, this is the mantra: we don't have enough money. From the director of the National Cancer Institute all the way down to the oncology fellow who's about to initiate his career in research. And I am so fed up of hearing this, because for a very simple reason, Jayant, think of this. The structure in America is that, let's say I'm an investigator who wants to study something in my lab about cancer. I will apply for a grant to National Cancer Institute. I get the money, I develop it, and I say, wow, this thing looks very good. It should be brought to the patient's bedside and tested in humans. Now, the testing in humans has to be done by a drug company, not the NCI, National Cancer Institute. Why? Because the money required for clinical trials is a minimum of $300 to $500 million, whereas the NIH or NCI gives a grant for $250,000 a month. So they can't afford clinical trials. So now I am beholden to a pharmaceutical company. Even having said all of this, thankfully, America is the most affluent country in the world. We have plenty of money to throw around. Do you know that today, if I was to find something very important in a preclinical setting on the bench in my lab and think that it can be brought to the bedside, the success rate of this is 5%. After all the hundreds of millions of dollars spent on clinical trials. In other words, what I'm saying to you is that 95% clinical trials today in cancer, 95% fail completely, and the 5% that succeed, what are we calling success? They improve survival by few months for 20% to 30% patients. That's success, really? So the question is that you asked is there not enough money? I mean, we spend about on an average $2.7 billion on one drug. 95% of drugs fail. Now you do the calculation, $2.7 billion per drug or 95% drugs are failing. So isn't it time to ask whether there's not enough money, or as you said, there's a better way to spend this money, for God's sake? But you see, we get so trapped into things. Right now, the goal seems to be that we are going to identify a mutation in a gene in ovarian cancer, in lung cancer, in pancreatic cancer, and we will develop a drug to target that mutation. One gene, one mutation, one cancer, one magic bullet will cure. This is the same model for 50 years. I say the following, and then I'll stop. 95% of our resources in terms of money and intellectual minds, 95% resources, at least in America, are being spent in studying these kinds of targeted therapies. And now immune therapies have joined some of this. If I was to put 95% of resources and money in ghosts causing cancer, 95% will be studying ghosts. 95% people who are studying cancer today in America think that genetic mutations cause cancer, when there is not one gene they have ever identified that consistently causes cancer, except CML in chronic phase. For God's sake, that's not even cancer. So, and maybe APL, but really by and large, 198 out of 200 cancers, you can't say any one gene or any cancer associated with one gene that happens, except for the exception I told you. So the question again comes to over and over the same thing: money. If you're going to financially incentivize targeting mutations, then everyone will study mutations and drug companies will target the mutation. If you incentivize as I said, if I incentivize ghosts, they'll think ghosts cause cancer and study that. What kind of nonsense is this? And where are all the adults in the room? Why is no one taking a full 380-degree view of the cancer paradigm? Because no one thinks of patients anymore, it seems. Everyone is in it for paycheck oncology. And the problem that's happened in America, Jayant, I'll stop with this, is that we managed to monetize human suffering at every level. We have commercialized human anguish. And so the two people who have skin in the game, doctors and patients, are the least important in hospitals anymore. It's all about hospital administrators who are going to make money out of every suffering that we have. And that's it. You tell me, why are we not taking blinders off? Now the whole world is following America's great example. Everyone has monetized human suffering the same way.
Very, very ironical, Azra, the way you put it. We are monetizing human anguish and perhaps missing the woods for trees. I think, as a non-healthcare professional, I mean, the way you describe it gives me a feeling that there is a need for the entire, the business process reengineering of cancer research, not just in the US, but all over the world, so that more disruptive innovations happen, not small incremental, interventions which give a few more months to the patient before the patient dies. I think it's on one hand, it's so heartening to see that you have thought about these things, but also it saddens me as a global citizen that why the world is not thinking on those lines. I think your book also talks quite a lot about early detection. We all talk about if you detect the cancer in the first stage, the chances are better. And even before that, before cancer appears, when the first cancer cell develops in the body, at that time itself. But we all know it is easier said than done. US is still a rich country, but in many parts of the world, especially in India, there are lots of gaps in the healthcare delivery chain. So even if you can't do it for the entire population, all across the entire, why can't we do more targeted, early detection programs for high risk categories like smokers, like people with genetic mutation, people with lung diseases, people who have repeat ulcers, or any such categories which can be identified as a health risk. So if we can't do it all across for the entire population of the US or the world, why can't we do it for these risk categories and do idiot proofing so that we detect, as you said, the first cancer cell as it appears in the body? So what stops us from doing it? I know there's a cost of doing early detection for the entire population, but this is a small segment, of high-risk categories. Why can't we do more focused intervention for them?
I have to start my answer by saying, Jayant, that I have the greatest respect for India for the quality of scientists it has produced, in biological sciences specifically. Because when I look around me in the United States, there is no area of cancer research where scientists from the subcontinent are not dominating in America. So it does mean that when our people are given the chance, they rise and shine like nobody's business, right? Now, within India, think of the following. Instead of trying to chase down the last cancer cell when we know the chance of success is 5% for a few months, why is India constantly aping America in this model? Because early detection would be the most helpful thing for India, yet they don't do it. Why? So while I deeply respect the intellectual and the emotional investment that Indian scientists have, and they own it, they work so hard, they're all trying to help patients, but they are not really, in a sense, I'd say that they're not looking at their problem as it affects India specifically, and they need to. And what would be the easiest is to find, the only good news we can give cancer patients is we caught your cancer early. So why not catch it at the earliest stage, not stage 1, because that already requires cutting by surgery or giving chemo or radiation. I'm saying, why not go to the earliest stage? Who is studying early cancer ever? Cancer is a silent killer. So by the time even a small tumor is detected, it's got millions of cells. And people keep asking me, well, how are we going to find an earliest stage of cancer? My answer is, don't wait for cancer to declare itself, because then it's at least a stage 1. Let's start monitoring wellness to find illness. I would love to monitor the whole healthy population of the world, constantly treating the human body as a machine and looking at with sophisticated technology 24/7. But in order to reach that stage, we should look at an enriched population, which means a population of individuals that you pointed out who are at a little higher risk of getting cancer. Let's begin with them. Let's see if we can find the first cell. I already have pictures of the first cell on my cell phone. We have got cancer cells years in advance of actual cancer appearing. There are published papers from a company called Rare Cells, which started doing this work 15 years ago. They are showing that 4 years before they can catch the first cell, and then finally the cancer appears on a PET scan or a CAT scan and it's removed in the earliest stage. Still, it requires that removal. Why? Because we're not investing enough money to target and eliminate that first cell. So the idea is very simple. The proposal I'm making is twofold. First, look, we have cancer patients today. We need to help them. So 50% of all our resources must go to try and help the patients, but do not hurt them by giving them these horrible therapies which are causing both physical and financial toxicity. Helping them doesn't mean we keep pushing drugs on them. No. Let's invest 50% of resources in current cancer patients in a humane fashion, and do for families and patients what will really help them, not help somebody's pockets get stacked with money. And the second thing I'm proposing is that 50% of resources should be invested in trying to find the first cell or the earliest possible inception of cancer. And like you so wisely pointed out, that would be looking at a population at high risk, like heavy smokers with lung disease. They are at a higher risk of cancer, things like that. And what we can do is simply save their samples. And once they do get cancer, then we have all the samples saved up. So you'll be happy to know that I have just received a grant for $15 million to do just that. And I've put together a think tank of 8 universities, which include Columbia, Harvard, University of Chicago, Johns Hopkins, MD Anderson Cancer Center, Northwestern University. I mean, these are the best institutions in the country, the best minds. We've all come together to say, okay, we're going to save samples on people at high risk. And you know what? This is being recorded. So within 3 years, I'm making a prediction. We will have 50,000 subjects between our 8 institutions whose samples we have saved. 2,000 of them will have developed cancer. By studying just those 2,000 patients, we will be able to shift the paradigm, because we will show the success of finding the first cell. To shift the paradigm, all you have to do is show success. I can talk till I'm blue in the face and people will keep criticizing me. But if I actually hold up the first cell and say, look, here is this patient on whom I found the first cell and now the patient is cured, well, that will shift the paradigm very quickly, because everyone will realize that's where the money is now. So what it comes down, but why should I be the only one doing this? Why should these 8 universities, the whole world, especially India? You guys should be the leaders in doing the first cell detection and early cancer screenings all over the place. Instead of spending time trying to develop CAR T therapies and immune therapies that are going to bankrupt an already stressed system in India. Why are you even developing those?
Absolutely. I think you very rightly put it. If you look at the US, such a substantive number of doctors are from India, or not just India, the Indian subcontinent. And look at the UK, in the NHS, every 2 out of doctors perhaps are from the Indian subcontinent, But you also pointed out that, how they are also falling, onto the beaten track. And they are falling in the same trap of American way of thinking, and not using the Indian ingenuity, to address the problem. But the project and the that you've got, I see a lot of hope and some ray of light at the end of the tunnel. as the work gets completed here. So now, Azra, I would like to shift the focus to India, because the book is being launched in India. And India, as we know, is a large country of 130 crore people. And it is ironical that, on healthcare, the public expenditure on healthcare in India is just about 1.3% of GDP. Of course, it does not include the private sector expenses, but government expenditure is very, very important on healthcare, because there are a lot of poor people who live in India. And if you look at the Indian statistics, we have almost 1.4 million active cancer patients in India, and this figure is likely to become about 1.6 million by the year 2025. So what's your, a lot of people who do not know where the next meal is going to come from, where survival itself is at risk and stake, how, if they are confronted with cancer. So what are those things that India as a country needs to do? Especially, the creamy layer of India, it can afford the best treatment available anywhere in the world, in the country and abroad. But how do we address, cancer interventions and healthcare solutions, for people at the bottom of the pyramid in India, who are really poor and who can't really meet both ends, leave aside getting money for treatment, and they are the people who are, even the healthcare insurance is beyond the category of people that I'm talking about, and they are in very, very large numbers, in millions and crores of people. So what's your of course this was not the subject of the book, but being a sensitive oncologist, I thought I'll pose this question to you.
Yes, of course. I think it's a question that is very close to your heart and my heart, because I come from Pakistan, you're from India. We are the same people. We are the same subcontinent, and we have the same issues. Of poverty. Absolutely. So I want to point out that this cell phone today is more powerful than the most powerful computer the world owned in 1970s. This one thing is so very powerful. Why aren't we, and to me, from beggars to delivery boys to taxi and rickshaw drivers in India and Pakistan, everyone almost owns the cell phone now. Why aren't we taking advantage of it? So one thing we can do, and India, I want to talk directly to the Indian scientists now. And I want to talk to the people who are financing this kind of science in India. Please do not try to constantly copy the West, because you can become leaders in no time, given the intellectual potential, the intellectual capital that India owns. My God, if you put together the Indian minds who are tremendous in biological sciences, the whole world on one side and India on the other side, America included. I'm being honest, I'm not trying to flatter you. Why not use all this potential properly? One thing you can do very simply that you're very good at is develop things like, I'm holding up something called the M chip. This M chip is right now FDA approved. It has been developed by a biomedical engineer, Professor Sam Sia at Columbia University, and I work very closely with Sam for many years now. All you have to do on this chip is prick your finger, drop one tiny drop of blood onto this hole. It will travel through microfluidics and reach the end where it will, right now it's FDA approved for detecting PSA, prostate specific antigen. So men, and then it can be read by simply inserting it into a phone-like device like this, and you can read the PSA level. And men sitting at home can monitor themselves for prostate cancer. If it's going up, they have to go see the doctor. Or if they already have prostate cancer, they can look at, is the therapy working? Is the PSA? They can test themselves 10 times a day sitting at home. Our idea is, why not make this into a protein barcode? You know, like barcodes at supermarkets. You have one bar for prostate, one bar for a protein specific to, let's say, CEA, carcinoembryonic antigen, which is telling us there's cancer somewhere, or pancreatic cancer, or ovarian cancer, lung cancer, breast cancer. And with one drop of blood, you can see which one's going up. Why can't India do things like this? Why do you have to develop all these fancy immunologic therapies and things like that? So I'm saying to you, and I'm addressing all of Indian scientists and their financial sponsors, that it's high time to have a high-level summit. Let's put our minds together and see how can we help that poverty-stricken 35-year-old mother that I talk about in my book, whose single mother of 3 little girls is now diagnosed with end-stage cancer, blood cancer. When I go to see her, before I even enter her little shanty, outside are sitting these 3 pale little girls, aged 5 to 9 years, whose only supporter is that one mother inside. So before I go in, they look so sick. I asked the girl, the oldest one, I said, "Are you okay?" And then the answer that she gave, my sister had received this answer also. The answer is so heartbreaking, Jayant. When my sister asked, "Have you had breakfast?" the child replied, "It wasn't my turn to have breakfast today. It wasn't my turn to have breakfast today." How do I go in now and talk to a 35-year-old woman for whom dying from blood cancer is not her biggest problem? Her biggest problem is sitting outside. She is supposed to get CAR-T therapy? No. We need to make cancer a global problem, a global issue, and we need to work in a way that addresses the problems of the lowest common denominator. Otherwise, we have failed. There is nothing like disease that equalizes all of us. I could be the president, and if I have cancer that's not treatable, I'm the same as this woman. So let us think of what will help this woman instead of thinking about how we can develop the most expensive. What will help this woman is, had we diagnosed her cancer early with very cheap things, like if she can afford a cell phone, she should be able to afford a chip like this that can be inserted into the cell phone very soon. How will this come? The only answer to cancer is prevention, and not prevention by lifestyle changes of fancy exercising gyms and eating well. Those are good things. Don't smoke, eat well, do exercise, but the people with the most pristine habits get cancer. So we have to do something more also. Yes, anti-smoking campaigns should be there, but at the same time, let us invest our intellectual and financial resources into developing technology that will be so efficient and so easily available to everybody universally, whether we live in India or Africa or America. At the same level, sitting at home, we can monitor ourselves, and it can happen. We just have to change the financial incentives.
Wonderful, Azra. I mean, you have in the book more than anything else. I think it is a human side of cancer treatment, that you have laid focus on, which has appealed to me, which I have really loved while going through it. As long as there are sensitive and conscious doctors, oncologists like you, I see some hope. I see some future for cancer research and treatment all over the world. I actually feel that your book would be an eye opener for a lot of people, not just the oncologists, not just the people who treat or people who do research in the space, but also the public policy professionals, who decide, how cancer as a dreaded disease, should be addressed from research as well as from a treatment perspective. So I'm sure this book would be an eye opener, and I would recommend this by anybody who has. And the good thing is, it is not written. I mean, it was. I first thought that I'm not an oncologist. I'm not even a doctor. So whether I will understand, but the way it has been written, it addresses even citizens like me, and so I strongly recommend this to doctors, to scientists, to researchers. Because not that it will give you breakthrough ideas, but it will open your mind as to how the world should look at healthcare interventions for cancer. So thank you, Azra. I wish your book all success in the country, because if the book succeeds, it's not just a question of a book doing well in the country. I fundamentally believe that it will change the way cancer research and treatment happens all over the world, and especially in a large country like India. So thanks a lot, Azra. I love talking to you for last few minutes, and all the best to you. And as they say, more power to you, Azra.
Thank you so much, Jayant. It has been a real honor, and the quality of questions that you asked me really get to the heart of the matter. And the heart of the matter happens to be the real heart, that we are connected emotionally also in this battle, whether we have cancer ourselves or we are caregivers to cancer patients. It really connects all of us at an emotional level. I'd like to end by quoting one sher of Ghalib, since you began by mentioning my Ghalib book. In this sher, Ghalib is talking to Jesus Christ and saying to him that you were able to raise the dead, the Lazarus effect. You could raise someone back to life who had died. Ghalib says that's easy to do, but what is more difficult, he says this. Ibne Maryam hua kare koi. Ibne Maryam, the daughter of Maryam, Mary's son.
Ji.
Ibne Maryam hua kare koi, are mere dukh ki dawa kare koi.
Kya baat hai?
It's easy to raise the dead, but it's much harder to find a cure for what I'm suffering from.
Bilkul, bahut khoob.
That is so beautifully said. I hope that everybody who thinks of the word cancer, whether it is from the most basic scientific level or the most advanced clinical trial level, or as a mother of a child who has cancer, or as a wife whose husband has cancer, everyone should be looking at cancer from this perspective of what pain and anguish and suffering it's causing. And we need to find answers to that. And you have been so amazing in bringing out this aspect, particularly, Jayant. I am extremely grateful to you. And thank you so much. I think HarperCollins, who are releasing my book, are going to be even more grateful to you to bring this to the attention of the Indian public, because after all, it will be pressure from the public that will change leaders.
Absolutely.
Adavars.
Azra, and all the best to you.
Thank you.